Hi, everyone. We're back live for the second segment of the ICES Winter Forum. I hope you had a bit of a break, got some food perhaps, a glass of water, and you can now settle in for what I know is going to be a terrific second segment to the day. It was just 49 weeks ago today that the WHO declared COVID-19 to be a pandemic. Human-to-human transmission of SARS-CoV-2 had only been confirmed by the WHO on January 22nd, and 3 days later, the first case in Canada was diagnosed here in Toronto. Those events seem distant now, and the telescoping of time makes them feel as if they're almost from another era. But even at that time, leaders internationally, nationally, and locally were already needing to make important decisions about how to respond to COVID-19. The frequency, the importance, and the impact of the decisions made have only increased since then. The information available to decision makers, the data and the analyses, the research have all increased dramatically, but we know the gaps remain. In our second panel today, we're going to hear from leaders who represent different perspectives to discuss how, from their perspective, choices and decisions made were enabled or hindered by the data information available to them, and hopefully draw some lessons and learnings for the future. I'm now going to briefly introduce our 6 panelists, but please refer to their full bios on the speakers page of the Google platform to learn more about them. I'm going to introduce them in the order that they're going to speak. First up will be Dr. Adalsteinn Brown, co-chair of Ontario's COVID-19 Science Advisory Table. Second is Anna Greenberg, Interim Executive Lead, Clinical Institutes and Quality Programs at Ontario Health. Third is Dr. Fiona Kouyoumdjian, Associate Chief Medical Officer of Health at the Ontario Ministry of Health. Dr. Andrew Baker, Incident Commander of Ontario's Critical Care COVID Command Centre. Dr. Kim McGrail, Scientific Director of Health Data Research Network Canada, who's going to give us a national perspective. And finally, Pete Stokes, Director of the Integrated Data Program at the UK Office for National Statistics, here representing also the International Population Data Linkage Network, who will give us a perspective from the UK. So I've asked each speaker to give some introductory remarks in the order that they've been introduced. And after the last speaker has done so, we'll begin a Q&A session where the panelists will answer your questions. So to all of the viewers out there, please don't be shy about filling the chat box starting now with your questions. And we look forward to getting through as many of them as we can. So now over to you, Steiny.
Thanks, Michael. So, I was asked to sort of make a few remarks about how did data and analytics support or not support our response to the pandemic. I guess that, the first caveat is it's always a little hard to talk about this when we're dealing with a new disease. When we're constantly refining what we know about the dynamics of the disease, how it's spread, how it's affecting different groups. And it's probably even more challenging to do so in a disease that has been so profoundly politicized in terms of how people value different outcomes associated with both the infection itself, but the broader pandemic and its impact on societies. But all that being said, and the usual caveats put to the side, I do think that data and analytics have had 3 important impacts. Some are very specific to the pandemic. I think at least a couple are going to be as important for the next pandemic or the next health crisis that we have to face. So the first place where it's had an impact is in public engagement. I think often when we get into debates about health policy or what our system should be doing, we, if not a data-free zone, we at least enter a very data-light zone with relatively little information given out, often just sort of small snapshots. But in the jurisdictions that have handled the pandemic well, they have been, I won't say maybe relentlessly, but they have been consistently, almost even daily, out providing data and updates on progress. And you can see, I think this is critical to any kind of free society or any type of democracy, that if you're dealing with a public health crisis, if you have transparency and you have sharing of data and of the analytics around everything, you actually build a stronger platform for engaging the public. And I know that's entirely opposite to what we're often taught about. Keep it simple, keep it light, don't provide too much. I think in this case, the burden of evidence or the burden of proof that's necessary is really important. And the more that you share, particularly if you share it clearly and you share it in a thoughtful sort of way, the better you are. And so I think Data analytics have had an impact. They have had an impact in how groups respond to this and how the public responds to the pandemic and the controls associated with it. But I think it's also had a good impact in hopefully starting to set a better platform for how we engage the public around critical health issues using data, or at least backed up by data. The second thing, place where I believe it has had an impact is it has had an impact on decision making. I believe for the most part it's been a positive impact. And it's had that, I think, work well when it's been, again, something transparent. I think there's often a great tendency to think that data and analytics are something that only flow upwards. There's something that are really only given to the highest decision maker on as a basis for thinking through options. But again, the more that we've been able to take good data and good analytics and both provide them to decision makers, but also help, I think, share some of that foundation for their decision making, it has had an impact. Whether that impact has been deep enough or strong enough or gone long enough, I think is always open to debate, but that impact I think is very clearly there with decision makers again. And even where you've seen jurisdictions take fundamentally different paths forward in how they're going to respond to the pandemic, it has, I believe, been in response to a clear sort of thought about the data, about the analytics, and what they think it's saying. I think the final place where the pandemic and data and analytics have had a big impact is on data systems itself and on our analytic approaches. It's made very, very clear how we struggle with gaps in our knowledge, whether it be the absence of data on race or on social determinants of health, the slowness of death data and other data, and all sorts of other limits on how we both use data to describe what's happening to people and describe what's happening to communities, but also how we share that data. And I never want to say that we're in one of those never again places, but I do believe that the importance of data has risen. And I'm hopeful that one of the lessons, although they often don't last as long as you'd want following a public health crisis, but one of the lessons is that we get in a place where we've got a stronger value on data and a recognition that's the sharing of that data, which makes it truly valuable. Michael, I think I'm sort of at my 5 minutes and I'll stop there.
So thank you, Anna Greenberg from Ontario Health. And last time I was here, I was at a fall forum and I was explaining what Ontario Health was about to become. We hadn't yet transferred, and as some of you know, it is the merger of 21 agencies. The downside of having gone into the pandemic as Ontario Health at the stage that we did is that we certainly hadn't designed strategically in any way the organization as we would have liked to, particularly if we'd known what was coming. The upside is that we were much better positioned to work together and as an integrated team under a single board in a time when streamlining and unified strategy was called for. And as one example of that, being able to centralize data and analytics across 21 previously separate organizations certainly contributed to a little bit of a shrinking of the noise. Many of you will know that it didn't completely eliminate it, but I shudder to think about what it would have been like if we'd had 21 separate organizations added to the mix. We played a variety of roles in the pandemic, and I'll just highlight the way in which we worked with PHO, with the ministry, with ICES, and with the science table to monitor the evolving strategy for the pandemic. So our scorecard, that was a shared scorecard across these organizations that hadn't worked as closely together I mean, none of us had worked on something quite like this, of course, but we hadn't worked on data and analytics in anything like the integrated fashion, which we had to before. And we certainly had to go beyond the strategies and boundaries of our organization to think about how and what we would monitor. So we were monitoring, of course, all of us, the spread of infection, cases, clusters, and outbreaks. We were monitoring our public health capacity and the extent to which our province was prepared to test, trace, and isolate. And we were monitoring health system capacity across a number of different areas. And these evolved with time in terms of their emphasis, but included telehealth capacity at the beginning, certainly supply chain, virtual care, long-term care capacity, hospital, home care, primary care, mental health, many different sectors. And then in post-wave one, immediately started to turn our attention to monitoring what recovery might look like in terms of COVID, non-COVID care, that had been put on hold to some extent through the pandemic if it wasn't emergent or urgent. So some of the key gaps that we see, I echo some of Stainy's comments. As we entered the pandemic and started to look to our first dashboard provincially, there was already several examples of high quality public dashboards. One that stands out to me was the one in Singapore that had almost down to the individual level of data publicly reported to guide the public and the government's response to the pandemic, and many, many other examples of this. And so I think what we saw in Ontario was both the official and the unofficial unleashing of data in terms of public reporting from a variety of sources, and social media being a very, very important channel for this. But never quite, I think, getting to that early Singapore type example. I think we could have anticipated this, but an incredibly heavy hospital focus. And this was not just related to where we all, I think many of us expected the pandemic to go in the very early days, based on where we'd seen it in other jurisdictions and what we'd seen with SARS previously, but also, as we all know, because of where our data systems were and the maturity of those. And so we did see silos across sectors and asymmetry in terms of what we were able to monitor, even if we knew that we should be monitoring other areas. And congregate living, whether it was group homes or long-term care homes, of course, turned out to be a significant example for us. And then, of course, having to deal with a lag in terms of the data for certain sectors like primary care or home care or mental health, where we'd like to be able to monitor those sectors in real time and how we're serving Ontarians, but nothing like the type of hospital data that was available to us. The other thing I'll just highlight is I think as a previous organization that had publicly reported in long-term care, it was fairly evident quite quickly that we were measuring things in long-term care that were not going to be useful to us at all in this pandemic. And we were going to have to look to novel data collection in a sector that was already short-staffed and not well-resourced. And so this was one of many areas where we were caught flat-footed in terms of our response. Health Human Resources was a notable Achilles heel of our response, and our lack of an ability to understand in near real time quantifying what our staffing needs were in long-term care is just one example of that. And then quite notably, having equity data limited to the neighborhood level. And I say this actually with deep respect for and gratitude for having had the On Marge data set because it was, we certainly used it heavily. But I think there is a welcome recognition that we need to get beyond that to the individual level, and that having bespoke data collection for individual level sociodemographics is not a sustainable solution, though I think incredibly important that many experts and community organizations advocated for this and actually succeeded in having us have some form of individual level data collection mid-pandemic. I'll just mention a couple of positive lessons learned through this. I think I echo Stainy's comments on data literacy. I don't think I've ever seen a media as literate in data, social media, and the public. And I think that's about having a steady diet of data every day and the ability to have data that gets corrected from day to day. We probably would in normal times say you shouldn't put out data unless you're absolutely sure about it, and we had to, and that meant that we also had to acknowledge where the data needed correction and where we needed to take cautions with data that was out in the public domain. I don't think I've ever seen in my career this type of real-time use of data for decision-making on a daily basis. And I think the ability with the scorecard we were using, at least in health, to evolve it over time as the strategy evolved and to experiment with what we were measuring, to throw away what wasn't working, to add new, and to include new data sets as we knew them. And I certainly think that was a positive discipline and practice for us as a health system. And then working across organizational boundaries was incredibly important. I see Fiona on the panel with me from the CMOH, my colleagues from PHO. We learned a lot from each other in terms of the expertise needed to interpret the provincial data sets. I think prior to this, there's a desire to just have as much data as you want. And I think we learned a deep appreciation for the subject matter expertise that's needed for any of these, but it also means that it forces a welcome collaboration across organizations and experts to make good use of it. And then I think we saw some novel data sets collected. I think we will always need this in a crisis. We'll have decent data to rely on. We will also need to have primary data collection, and that kind of prioritization is not easy to do. And it's certainly not easy to place reporting burden on a sector or a set of sectors in a time of crisis, but we know that it was necessary in many cases. And then I think I'll just highlight interesting linkages of data. The example I would give is that ICES in Wave 1 helped us to look in particular at testing data in long-term care homes, which is a major priority on a daily basis. And certainly we need to have more of that. We probably didn't link enough of our data sets to this pandemic. I think that was a good example of it. And then lastly, interesting at the end of the day, we are probably still most confident among all of our metrics in the ICU data that we have. And I say that interestingly because this is a set of data and information that came directly out of SARS-1. And I think interesting to have been able to rely on that and the refinements that were made in Wave 2. So I will pause there.
Great, thanks. Happy to present as part of this panel. I have two key messages that I wanted to share. The first is that this coronavirus pandemic has really presented a policy window to make changes to improve public health and thereby to support population health. Within public health, when we do a good job on prevention, you don't see the bad outcomes. A lot of the work that we do is very much in the background, and that makes it hard to justify major investments and the costs that are involved in the ongoing business of public health in what we might call regular times. That being said, we know that these structures need to be in place to support the important work that public health does on an ongoing basis, again, which is often invisible, and then in particular that is highlighted during crises. This crisis, as has been the case in previous crises, has exposed issues that need to be addressed. A few of them, for example, are challenges with our public health data system. So in the midst of a health crisis, having to have a major overhaul, and in some of our 34 public health units, doing this twice, implementing new data systems. And these systems are really critical. They not only record data on reportable diseases, but also support the nitty-gritty, detail-oriented, and sort of detective work of case investigation, which we rely on so much to understand our epidemiology and in turn to inform our interventions. Another one, recognizing this audience in particular, we don't have our reportable disease data available at ICES. So how can we use this moment in time to make the data available as part of our understanding of what the health of people in Ontario, what the health status of our population is. And then last, which Stani and Anna both referred to, this increasing focus on health equity, including through the collection of data on race that has been advanced during this time, both because of the pandemic and then, of course, related issues in terms of horrible events in the spring and increasing focus on anti-racism more broadly. So while I talk about a policy window, of course, to be able to move during the time of a policy window, we need to have our solutions ready. And that includes having our ideas ready and having the structures in place to support our ability to implement those ideas. So, certainly, I think many of us wish we had been more ready to move during this policy window than we are. The second key message that I want to share is that during crises, we need to be able to increase public health capacity. And this has been flagged after previous crises, of course, also, and you know, more recently outside of the context of crises by Canadian Public Health Association and other organizations. So within our existing public health structures, we need to have so-called surge capacity or reserve workforce. So it can't be that our public health structures are already functioning at 100% or 110%, because inevitably, whether it's a church picnic, to use sort of the classic epi example, or hepatitis C outbreak, or a coronavirus pandemic, we need to be able to respond when we have increased demands. And this is across all the parts of surveillance and response, so data collection, analysis, interpretation, communication, as well as action. And when we have a major crisis like the coronavirus pandemic, we can't, the volume of work that's involved can't be accomplished by only our public health structures. So I've been very impressed by the structures that have been developed relatively quickly, including many on the call, to support the ongoing needs for data collection and analysis, and that's within government, with government agencies, and with partners in academia. You know, that being said, I think although within a crisis, we of course need to tailor specific relationships, structures, roles, ideally we would have relationships and structures in place before a crisis happens. These are predictable things. We know we're going to have another public health crisis, hopefully not the size of the current one. How can we set up to have our infrastructure, our relationship,
I think we lost Fiona. Well, hopefully Fiona's going to come back. We'll try to message her. But in the meantime, perhaps while we're waiting for Fiona to come back, Andrew, do you want to step into the breach? And we'll Fiona finish her comments when she comes back.
Okay, my pleasure. Thanks a lot, Michael. Yeah, I want to give my comments in the context of being one of many, data analytics users, consumer. I've been as you mentioned, the incident commander since March 2020 for the IMS that deals with all ICU beds in Ontario, and since November 2020 as well, the incident commander for an IMS that deals with all hospital beds in the Toronto and surrounding area. And really, the challenges that we faced were related to both immediate and anticipated issues, and I want to stress that. So the threats that we dealt with in the immediate sense included patient safety and sentinel events related to elevated demand capacity ratios, impaired functional integrity at the level of a ward, an ICU, a hospital, and even a regional network of hospitals, including transport systems. There are also threats, of course, to healthcare workers' safety and health, strain, burnout, mental health, and of course the impact of healthcare worker health and number on functional on care itself. Finally, there is the threat to functional integrity of the system overall in terms of access to care for life-threatening COVID disease and non-COVID care. And this included the insidious threat to timeliness of care for important non-COVID care for conditions that they themselves had inherent impact on mortality, but were functionally deprioritized because of their longer time course. At the next level of resolution, the issues that we dealt with included the number of ICU beds. This is both immediate and anticipated issues. Ventilators, critical medical supplies, not only PPE, but everyday ICU consumables. The rapid depletion of common and specialized drugs, as well as emerging therapeutics. And of course, the most important, the number of trained and available nurses, doctors, RTs, and other professionals. Of immediate relevance to us was the highly uneven incidence and presentation of COVID and severe COVID in those places, and the absolute rise in the number of cases, raising the risk of all of these threats that I mentioned at local levels to a very high degree. That COVID results in a distinct cohort of people that have a truly life-threatening version of the disease, but who would be able to survive if they received ICU care, made for some very compelling challenges in this pandemic from our perspective. So while addressing immediate threats and mitigations of risks as they arose, concurrently we conceived of the anticipated issues of scale. Projecting scale pointed to qualitatively and materially different and challenging issues requiring commensurately more complex and resource-intensive proposed solutions. Inklings of what this could look like arose not only from international experiences brought to us through formal and informal routes, but also what the very beginning may look like when highly local sudden surges were experienced in certain areas of Ontario. So anticipating and preparing for the projected scale of demand and addressing the various components was in itself a demanding set of exercises. We use both provincial rolled up and local projections based on population epidemiologic projections, as well as hospital census-based projections to anticipate demand. In addition to human resource planning, supplies, and ICU bed planning, we directed movement of patients. Movement of patients was both rescue, where immediate risk was identified, as well as proactive in order to load balance and mitigate the local peaks that threatened to overtake safety thresholds. In all, we've moved about 1,000 acute care patients and about 200 ICU patients directly related to COVID. Finally, in terms of locating the real impact, health impact of COVID, there's been the mortality in long-term care, of course, and other non-hospital locations, the morbidity and mortality of COVID in hospital wards and ICUs. There's been all the impacts of lockdown, but there's also been the impact of reduced access to care, not only from immediate demands, but also arising from our preparation for the projected demands. Therefore, as one of the principal users of data and analytics, we spent much of our efforts dealing with not only immediate, but addressing how we might expect to manage the impact of what was projected. I'll stop there, Michael, and look forward to our discussion.
Great, thanks, Andrew. And I noticed Fiona's back. Welcome back, Fiona, one of the travails of a virtual conference. Did you want, I just want to give you an opportunity to finish if you had some final points to make.
I sort of feel like that, like drop the mic exit was nice and dramatic. I was just going to read something from, I hope that you heard up to this point, but from the Naylor report, again, like, you know, could be speaking about the current coronavirus pandemic. The SARS story, as it unfolded in Canada, had both tragic and heroic elements. Although the toll of the epidemic was substantial, thousands in the health field rose to the occasion and ultimately contained the SARS outbreak in this country, notwithstanding systems and resources that were manifestly suboptimal. The challenge now is to ensure not only that we are better prepared for the next epidemic, but that public health in Canada is broadly renewed so as to protect and promote the health of all our present and future citizens. So I'll stop there. Thank you.
Thanks, Fiona.
Okay, so I think it's over to me now. And thank you for the invitation to be here today. It's really an honor to be part of such an esteemed panel. I was, as Michael said, asked to speak from the perspective of Health Data Research Network Canada, which means pan-Canadian, but also specifically a research perspective. So one of the themes that has come up already quite a lot today is that during this past year, during the pandemic, we've seen clearly a lot of problems that already existed. So it's like shining a spotlight on things that were already happening and in some cases making them, of course, far worse. I think the key message here for us is that your ability to respond to a crisis situation like a pandemic really depends on how well-oiled your system is to start with. So if you start with something that's a little bit chaotic, then it's going to be awfully hard to pivot and respond appropriately. And in truth, our pan-Canadian ecosystem for data and data sharing has needed some attention for some time. Some parts do work well, but other parts really do need some more work. And so I wanted just to speak really briefly about the challenge of data and the challenge of analytics. And a lot of the points that I wanted to make about data have already been made. So this has to do with speed, how quickly can we get data flowing, and of course, that depends on the people, process, and technology you have in place to collect and move data around, how comprehensive data are, and how quickly we can respond and get in place the new kinds of data that we might need, or novel kinds of data that we might need in order to respond to the crisis at hand. We also have a bit of a challenge with the readiness of data. So we have laboratory data that are collected, but they're a bit messy. They need to be normalized in some way. They need some attention before they're really ready for analysis. And on top of that, of course, we have the testing data. In the case of COVID, there's been differences in the way the populations have been tested, the way they've been tested, the different tests that have been used. So it creates a lot of need for nuance understanding when people are analyzing and interpreting the data. So then I'll move on to really some of the challenges of analytics. And I think part of this has to be that you just the challenge of analytics relates to the challenges of data. But beyond that, I think another thing that we've done is, to this point, I think our focus on the research that's needed related to COVID is a bit narrowly constructed. And what I mean by that is what we've been really concentrating on is what policymakers need now, which is totally appropriate. But I think we also need to provide some space to try to anticipate what policymakers might need in 6 months or 12 months and get some of those things going, because some of this analytic work is going to take some time. Another challenge that the pandemic has made clear is that we really need to rethink our paradigm for science. And here I want to give a really big nod to ICES, because I think this is something that that organization has done very well. But we need to expand this further. So adopting a commitment to replicability and reproducibility in science, which means sharing code, documenting analytic approaches, and continually building on the approaches to analysis that had come before ours. So I think that is like fundamental change in the way that a lot of researchers work, and it's something we need to embrace. Of course, if we do this, it means we can get better science done in a more timely way, and it will also produce more transparency. So those are all good things. And to close, I would just be remiss in not saying that our approaches to use data do need to be grounded in strong public and community engagement. And at this point, I'm echoing something Steny said. I would just, underline that it's really, really clear that public trust has been the most effective public health tool at government's disposal. I would just add that I think to this point, engagement has been a bit one way. We're communicating to the public. We're not necessarily doing as much as we could to communicate with the public and hear back from the public what they need, what their questions are, and what the priorities and concerns are going forward. So I will leave it at that for now.
Thank you. I think that hands over to me. So first of all, thank you for inviting me to take part in this from the other side of the Atlantic. So I'm going to give a perspective from the UK and how data has informed the response to the pandemic here. A lot of what I plan to say, others have said, and in the interest of giving enough time for questions, I'll leave some of that out. But the situation here was very similar to others around the world, really. We had very little data to start with. There was a new disease. In the UK, we had very limited testing capacity to understand the spread of the disease, but hospitals were filling up quickly. So government needed data. It needed to start getting more data quickly so that it could make effective decisions about how to respond to the pandemic. But also, as others have said, including Kim just a moment ago, the government needed data to be able to justify those decisions to the public. You can't tell people they've got to stay indoors for 3 months without being able to use data to explain to them why it's important. It's not enough to just try and scare them. So when we started collecting data, what we found quite quickly in the UK is that, as is true across the world, you could see the people suffering from the disease with different levels of effect depending on different groups of people. So unsurprisingly, more elderly people suffered more severe symptoms than the young, but we also saw a lot of a differentiation between people from a different ethnic group or different race. I think I heard someone say previously, if that's the language you use, different ethnicity, different race. But what we couldn't tell, because the data wouldn't tell us, is whether that cause was because of the person's ethnicity or there was another factor. In the UK, certain ethnic groups are more likely to live in larger households, and therefore spread is likely to happen more easily. But also, they live in certain parts of the country where there was already a higher prevalence of the virus, or they're more likely to work in occupations which lend themselves to easier transmission. So we didn't know whether the trend was biological or societal, and it's really difficult to target an effective response if you don't know that. You don't know whether you're trying to target people of an Afro-Caribbean heritage, or you're trying to target people who work in public transport, because there's a strong overlap between those groups in London, for example. And the other problem in the UK is that the way government data are held is disaggregated largely by function. So health data are kept and managed wholly separately to other data. And actually health data on their own aren't enough. To be able to get an effective response quickly to this, you need to be able to join data from different sources together. We needed to be able to, for example, link our health records with our census data to get good data on ethnicity, good data on occupation, good data on household structures that don't exist elsewhere. And we also, though, in trying to then respond to the pandemic, we very quickly realized as a nation, actually, we need new data, and actually, therefore, you need to do new primary data collection, which I think Anna said. We needed to do new surveys. It wasn't enough to look at hospital data with the lag in those. We also wanted to be doing surveys and random testing of people around the country to understand the spread of the disease, so that we could monitor that, so that we could keep reporting it to the public and inform the government policy. So there's new big nationwide surveys have been implemented and are still running to track the disease, but also specific studies for specific situations. For example, retirement homes. We have a survey that runs in retirement homes, another that runs in schools, to see the spread of the virus there. And more recently now, we're doing a lot of work to understand the genomic sequencing of people who've tested positive with the virus, where they've tested positive, to track new mutations, in order that government can make further effective interventions in geographic locations where there's a spread of a new variant that is potentially at risk. So I'll wrap up there. My final thought is that what this is really critical, and I think this is true across the world, is that what the pandemic has shown us is that there are shortfalls in the way we manage and use data within government to respond to crises. And the pandemic has given us an opportunity to show that we can fix those problems and do things better. We can use data more effectively, we can bring data together more quickly, and we've been able to do that in a crisis. And the really key lesson for certainly the UK government, and I suspect others around the world, is that we need to build on this now. We need to cement that and make it a permanent part of our data infrastructure, so that we can respond to future crises more quickly and more effectively. And now I'll hand back to you, Michael.
All right. Well, thanks, Pete, and thank you all the speakers for terrific comments to set the stage for Q&A. So we have questions in the chat. I'm going to encourage the participants listening in to send more questions in if you have them. And I think actually I'm going to turn. I had told the panelists that I had some questions prepared that I've shared with them in advance, but I'm going to go straight to the chat, because there's some good questions in the chat, and we may come back to the questions that I have. So here's the first question for you, and I'll just open this up to anyone who wants to weigh in. Given that Canada is behind other countries in terms of the number of vaccinated individuals, are there any COVID-related topics that we are uniquely well positioned to research and study, given our data and or the ways our health systems operate? So are there any particular Canadian insights, given the state of the pandemic and vaccination and so on in Canada, that we are positioned to look at? Does anyone want to take a first stab at that? Stokes.
Well, so if we're going to be experiencing this longer, I think we can start to look at the long haul COVID issue. I think we can start to look at some really profound issues about health system resilience that, Andrew kind of referred to, and the last quote that Fiona shared referred to as well. So I think there's a wide range, and that range from, what would be sort of a clinical question right through to what would be a profound sort of kind of macro system level issue. Where I think Canada might be most interesting, or where at least Ontario might be most interesting to look at, is the really big macro system issues, as we try to understand, what has actually happened to our system and the people who work within it, and what should we actually do. Is we probably have to contemplate something like a Marshall Plan to rebuild, both our health and our public health systems.
Kim.
So I would just underline what Stani said and just add to that. I think in Canada, we have a long tradition of understanding and valuing the social determinants of health and their implications for healthcare systems and, of course, the health of populations. And that juncture of social determinants and healthcare systems, as Pete so rightly underlined and others have commented on, as an area I think where we do have some data strength. We certainly have some analytic and theoretical strength as well, and it's going to clearly be an important area, because this is where COVID touches not just the people who've been infected, but the entire community and society because of the effects of lockdown and everything else. So I do think that there's lots of opportunities in what Stani said and that addition.
Anyone else want to weigh in on that one? Okay, so let's go to the next question then. And this question, again, can be really for anyone, but I might ask Anna, given, and Fiona, in fact, given the roles you play in the system. This question is, how can transparency of information based on data and analytics be used effectively to counter alternative facts and fake news?
So I think that the question has the answer in it, which is that transparency of information coming from, it depends on your vantage point, but credible sources and actually having an official source can be a way to counteract that. I think what we've learned in the response, and it's actually guiding how we're doing community testing, how we're doing community vaccination, is the importance of community leaders in being engaged and very involved in the provincial plan or the regional plan, what have you. And so I think to the extent that someone might not trust politicians in terms of data as their first choice, I certainly think that if the public engagement and the community engagement that Kim talked about, it's not just one way, that people feel ownership of what we're measuring and what we're communicating, I think you'll have a better bet at reaching the public and various communities.
Yeah, I mean, just to add, like, it strikes me that, of course, we want to have transparency, because I think for people to have an understanding both of what's known and what's unknown, and also, what are the factors that are leading to decision making, at least to the extent that these things can be transparent, helps for people to actually be able to accept a certain whatever piece of information, or makes it more likely that they might pursue a certain course of action if the factors are in place for them to be able to do that, because of course we know there are many barriers to people following recommended public health measures. But yeah, so it's the transparency, I think, as a principle is there, but I think it has to be sort of coupled with effective communication in terms of what messaging looks like, what are the routes that we use to communicate with people, to support people doing the things that we're asking them to do, which are, in order to support population health.
Great, thank you. So this question relates to the health system, really, but Fiona, you also touched on it in terms of surge capacity in public health. And regarding the need for surge capacity, whether it's in public health or whether it's in the hospital system, and certainly this is something we've seen the need for in Ontario, Andrew, the work that you've done around ICUs and in the UK as well, which has been, in fact, much more heavily, the hospitals have been much more heavily burdened, I think, than ours so far. This question of surge capacity, both in acute care and public health, given that our systems run at full capacity pretty much all the time, and HHR is actually not easy to simply produce in the context of a sudden crisis, is that really realistic to be talking about surge capacity? Is there any jurisdiction that has actually managed that? And what would your recommendations be, whether it's in public health or acute care, around helping us become more adaptable and to be able to surge when it's required? Who wants to tackle that first? Andrew, do you want to take a first go?
Sure. I think it's a complex question because I think, resources are not infinite, and we want to use them wisely. And that's a very real thing. So in times when we don't need surge, we certainly want to do things with our resources that are productive. And there's lots of productive things to do in healthcare. And so, the answer, is not necessarily to produce excess capacity and leave it unused. I do think there are such things as optimal occupancy rates. And I think that you can develop a sort of deficit in that regard and slowly erode your optimal occupancy rates and sort of work at maximum capacity all the time, and that's a problem. So that's one strategy. I think the other thing is to have specific plans in place for how one would flex and redeploy HHR, and have different models of care, as well as different sort of opportunities for people to work at varying rates and that could be scaled up and down at times of surge. So I think there is an opportunity, I think, and lessons learned from this last year that we could take forward. And I think the important thing, Michael, is not to forget what happened this year, to look at where we really stared down the barrel of the numbers we were receiving from Staney Brown and others, and what we were anticipating in terms of HHR, and say, okay, now let's get some really smart managers and program directors to say, how would we manage a hospital and the hospital system differently with that in mind? I think it's possible.
Michael, can I jump in?
Sorry, I was on mute. Yes, Stanley, please.
Yeah, so I'd really kind of build on what Andrew said. I think there's two parts to this, which is more and there's a better part, right? The more part is that if you look at our hospitals, we really do need more. We really do run our system way tighter than we could. And I think sometimes we pat ourselves on the back with how well we do with what we run, and we say it's the least bedded in jurisdiction in the world and so on. But at the same time, I think sometimes we do ourselves a disservice when we say, oh, well, we could be getting a lot more out of this. There's always more efficiency, and that's true. But I think there is just an issue of needing more in our system. And I think there's the issue of better. And Andrew's, I think, put his finger right on it when it says, we need to actually be able to use the data better. We need to be able to deploy better. We need to be able to manage better. That's true. But I think there's also this issue of integrating our system so that we can kind of get ahead of a bunch of things. And although, you never want to hold up the overall U.S. system as a model, the amount of innovation that goes on within individual parts of it around, say, getting upstream and dealing with the social determinants of health, the amount of innovation around different approaches to integration, a little bit of that, I think, would go a long way with us, both with dealing some of the huge equity issues that we've seen, priming our healthcare systems to deal with it better, as you saw with a few organizations in Toronto that actually did get ahead of it a little bit. And my sense is, looking at the Ontario health teams that have had a little bit better preparation, they've actually responded to the pandemic better as well, in part because they're roots in the community.
Thanks, Danny. I might just ask Anna to weigh in here, given that Ontario Health has responsibility for the hospital system. I know it's not exactly a direct response, but anyway, maybe just comment on this question of surge capacity.
Yeah, so I think one of the many lessons we learned in between wave 1 and wave 2 is that the extent to which we ramped down to the bare bones of emergent care in wave 1 was not fully necessary. And we didn't know that at the beginning, but I think we took the opportunity of in between wave 1 and wave 2 to say we weren't going to take that path again. We're going to try and optimize care and be able to have what Dr. Chris Simpson called a dimmer switch on our capacity, and to be able to preserve as much non-COVID care as possible with actually based on a fairly deep understanding of how much the backlog was accumulating as we went. And so when we look at the most recent data on the extent to which we ramped down surgeries in wave 2 compared to wave 1, we had a huge improvement on the one hand, just in the aggregate. And then when we looked at it by priority level, we certainly saw a deliberate strategy, at least provincially, that the highest priorities procedures were prioritized in wave 2. Certainly not in a way that could get us back to diminish the backlog as much as we'd like, but certainly we found that we were able to do that. And I think Andrew's guidance taught us a lot about the thresholds of the ICU and when we would get to a certain COVID census and the impact that would have on non-COVID care, and that certainly bore out. But we definitely learned that we could not completely reduce all other care at the expense of COVID care. The only other thing I'll say, because the questioner was asking about acute capacity and public health capacity, I'm certainly not a public health expert, but I do just want to comment on the fact that some differentiation between what is skilled resources that we need for surge and what are less skilled and trainable resources that we need in a surge, and how we can use lockdown as a way of building up particularly unskilled workforce where it could be helpful. I certainly think we had the experience in the province of, at least anecdotally, many people saying, I volunteered to serve the province and I wasn't able to be deployed. And I think what we learned from that is that it's the easy part is getting people to sign up. The hard part is effective redeployment of people. And I think that is a skill, whether it's HR or military or what have you, in terms of in a crisis, how do you deploy skilled and unskilled workforce?
Pete.
Thanks, yes. Just to offer, again, a UK perspective and really to pick up on a couple of Anna's points. I mean, I think the surge capacity obviously comes in two ways. It's by getting people to work longer hours to cover more, and by diverting resource from non-critical care effectively. And both of those things are kicking the can down the road, to use an expression which at least has currency in the UK, because there's payback there. You just have more non-critical operations to do when the pandemic eventually passes, which is going to take years to clear up, and the people who are working far too many hours need a break. So it causes us a problem. And in the UK, as the way Steny was describing your system, we do run the system at full capacity all the time, and often applaud ourselves at how efficient the NHS is and in terms of how it spends money. But what has happened in the UK is a use of, increasingly is a use of semi-skilled, I guess, resource for those tasks that can adapt it. Initially, when we needed people to be getting tested for COVID, that was being done by trained nurses. Actually, now that isn't necessary. The tests are largely self-administered. So we've been able to significantly ramp up the volume of testing for COVID as a result of using volunteer staff or very temporary staff. And the same is happening with the rollout of vaccines in the UK at the moment as well, where we're administering hundreds of thousands of doses a week, largely through use of a volunteer workforce, not a trained public health workforce, other than in supervision, which I think has helped us to achieve where we've got to with that so far.
Thank you. So we have about 5 minutes left, and so I will probably only get one more question. I'm sorry to everyone who have been asking, who've been filling the chat with questions, because there are lots of great questions that we won't get to. But here's a question for all of you, anyone who wants to make some last comments. Just keep it brief, because we only have 5 minutes for everyone. you know, we tend to count the things that are easy to count. And we've been talking a lot today about hospitalizations and ICU transfers and so on. But there are things that are harder to count. And that one example of that is mental health care in the community, or the mental health status of individuals in the community. And we know that the effect of the pandemic and some of the measures like lockdowns and so on can have deleterious effects. So the question from the audience here is, how can we move forward with a provincial or national, and let's think national includes the UK, plan for mental health data standards and an approach to monitoring the mental health burden that can be able to give us some sort of a sense of what is happening in terms of mental health as we try to fight this and perhaps future pandemics.
Maybe I'll just comment. And I don't know, Michael, if people have heard from Dr. Kouyoumdjian yet today, but I'm sure he'd have a lot to say about this. I'll just say that certainly there have been pan-Canadian efforts and provincial efforts, the most recent one being the mental health strategy currently, and Ontario Health playing a role in trying to advance the provincial mental health strategy, and like many other things has been focused over the past year on pandemic response with the mental health sector, including congregate living, etc. Some of the strategies that we're going to use is not to go from 0 to 60 immediately in the community mental health sector, but to build on some work that's happened certainly in Toronto region, to say what is the minimum data set for community health agencies in a way that will be useful to track utilization and activity and eventually quality. And I think that is an important strategy, and it sets a bit of a quality bar in terms of community agencies in the province to be able to meet and even exceed that minimum data set and be able to collect that provincially. The question also touched on burden of mental illness, and I think this is where the mental health status is something that we have relied on, but kind of our current data set on that is very lagged. And so I think it is probably this pandemic highlights the need to have very much up-to-date self-reported mental health status in addition to health status for the population, coupled with the activity in the community.
Fiona, do you have any thoughts from the CMOH perspective, perhaps?
Well, from Fiona's perspective, yeah, I mean, I was just thinking as I heard Anna speaking, and you did speak about both mental health and mental illness, but I mean, certainly from a public health perspective, a focus on health promotion. So of course we need to understand what the population level needs are, as well as the needs of specific subgroups, which might have been disproportionately impacted by COVID infection, and of course also by the public health measures, and then thinking about appropriate strategies that will promote mental health as well as support people with specific mental illness. I mean, I think this is work that involves collaboration across sectors, and yeah, certainly hope that we can, do a better job on this moving forward.
Pete, please.
Thank you. Yeah. So one of the things is to pick up on the point about self-reported mental health. One is since 2010, the ONS where I work have run a social survey on well-being, which doesn't just look at health, but it asks people every quarter about their physical and mental health, their relationships, education skills, where they live, their employment status, and how that makes them feel, that their well-being. And what that survey showed last year, unsurprisingly, is that how people felt about life went down on every measure, but particularly on mental health, where we had a significant increase in people reporting higher levels of anxiety and general unhappiness. So while it's a sample survey, it's not the answer. It has been helpful in informing government and helping them to respond, making sure that when in the UK people are put into lockdown, our lockdowns don't mean people can't leave their house at all. We are specifically allowed out for a period of exercise each day. A lot of people in the UK don't have any outside space in their homes. They're explicitly allowed out to some green space to go for a walk or to go for a run or to ride a bike to help with their mental health. So that's how we've tried to tried to use the limited data we have to in this response.
Okay, Kim, 30 seconds to close it out.
Okay. So I just clearly the mental health effects of the pandemic are incredibly multifaceted, either exacerbating underlying conditions or experiences, or the anxiety among young children of being separated from their peers and all sorts of things. So I actually think this is a very clear case where we do need to go and engage really deeply with the public and community organizations to understand all of the issues, and then to mobilize a response that cuts across the healthcare system, the public health system, and community organizations to bring this back together. This is a project for the next decade or more, and I think we need to do it right.
Well, no doubt COVID-19 has left all of us with work that will last at least a decade, if not many more decades to come. So listen, thank you all for a terrific panel discussion. I offer you all a round of virtual applause. I'm sure everyone online is joining me in that. So thanks again to all of you, and we'll now move on to the next segment of our day, which is a plenary presentation from Dr. Irfan Dhalla. If you follow social media and are interested in COVID-19, you will likely already know and admire Irfan. Irfan has been prolific, he's been measured, insightful, analytic, and practical in his commentary. And he also must be an insomniac to maintain the pace of posting that he has. But Irfan has done much more than that. He has been a passionate advocate and leader for healthcare quality for many years. He is a vice president at St. Michael's Hospital, a general internist who continues to see patients and has cared for many COVID-19 patients in hospital. And he's the current co-chair of Canada's National COVID-19 Testing Strategy Advisor Panel, I'm sorry. And please note that Irfan's presentation is going to be followed by a Q&A. And so again, please populate the chat with your questions, and we'll get through as many of those as we can. So Irfan, take it away.
Thanks, Michael. Can I get a thumbs up from you if you can hear me?
I can hear you.
Okay, super. So thanks, Michael, again for inviting me. Thanks everyone for listening. Michael and I talked a little bit about potential topics, and we thought we would do something a little bit provocative. So I'm going to spend about 15 or 20 minutes putting forward a case for why we should aim for elimination and why this might be the best path out of the pandemic for us, and then hopefully we can have a little bit of Q&A. Let's see if I can get the slides to go. So just to recap, what are we trying to do? Minimize morbidity and mortality from COVID-19, that's pretty obvious. Minimize excess morbidity and mortality from other illnesses. Both Staney and Andrew Baker and others in the previous panel talked about this. Opioid overdoses would be one example. Delayed diagnosis of cancer would be another. Keep schools open, keep people working. And then finally, and we don't talk about this as much as we might, have society function as close to normal as possible. A good example would be my 79-year-old father living in Vancouver, hasn't seen his children or grandchildren for nearly a year now. You know, when do people, he's not working anymore. He's obviously not going to school. Hopefully he won't suffer any excess morbidity and mortality either from COVID-19 or another illness, but there's no doubt that his quality of life is substantially impaired. So here's the argument in brief. We're trying to solve a complex, dynamic, definitely changing over time optimization problem. And I'm going to argue that aiming for elimination is the best strategy for solving this complex problem. And crucially, it depends on accepting that aiming for elimination is not the same as achieving elimination. And there's a little bit of confusion about this, so I'll take you back to a paper published in 1999, looking at various definitions of public health strategies. And sometimes I think eradication and elimination get confused. Eradication is getting rid of a disease in the whole world. Smallpox would be a good example. Actually, some argue that the first SARS has been eradicated. Some wonder whether there's still an animal reservoir for that. But basically, when it comes to Canada and COVID-19, we have taken for most of the country, a control strategy. And I think useful to think about what is a locally acceptable level of COVID-19, and did we ever agree as a society on what was a locally acceptable level of COVID-19? Elimination of infection, a little bit different than elimination of disease, maybe a slight technical point to think about with the introduction of the vaccine. The vaccine may prevent more severe disease than it does infection, but for the purpose of this argument, I think this is more a technicality than anything else. I do wonder whether when we're through the pandemic, whether there will be public health experts who sit down and actually redefine some of these concepts and maybe even introduce new ones. The word suppression gets thrown around a lot. And all of these terms actually are used differently by different people. So at a high level, here's some reasons to aim for elimination. And then I'm going to go through these one by one. So first point I would make is that the tactics are essentially the same for control and elimination. And they're all the things you've heard about that we've talked about: testing, case management, contact tracing, etc. Restrictions and lockdowns end up being a feature of both. And nobody likes lockdowns, of course, but whether you have a control strategy or an elimination strategy, the experience around the world has shown that we do need serious restrictions or lockdowns at various times. But I guess I wonder that if we aim for elimination, are we able to marshal resources more easily than if we have a control strategy? And to give you an example, and Fiona talked about this a little bit when she was talking about how the public health sector can never really be prepared for a pandemic like the one we're in right now. I think about how we have spent a lot of extra money on acute care. There are many hospitals in Ontario, for example, that are spending 10 or even 20% more than what they spend in a typical year. But my sense is that public health units haven't been given the leeway to spend as much as hospitals have been able to spend. Somebody else in the previous panel was speaking about volunteers and our ability to marshal volunteers. Maybe if we had explicitly set a goal of aiming for elimination, maybe we would have been able to marshal volunteers more effectively. More focus and attention on data. So, the ICES dashboard is amazing. I've looked at it many times over the last months. But one thing, we like with all data, we are driven by what data are available. And so the data that are most prominent on the ICES dashboard are data with respect to cases, data with respect to test positivity, highly granular, stratified, very useful for making some decisions. But we have very limited data in Ontario on things like contact tracing, adherence to isolation and quarantine, data about what is happening with respect to travel and the borders. And sometimes I think if we had an elimination mindset or set aiming for elimination as our goal, we would have collected more of this data and used it to drive an improvement strategy. And maybe the best example of where we could have used an improvement strategy better is at the border. We have thousands of truckers coming in over the border every day, and really, I'm not aware of any data on what proportion of truckers coming across the border are infected with COVID-19, and whether if we implemented some sort of testing or modified quarantine or support program, whether we would be able to reduce the burden of cases in Ontario. This paper is only 2 pages long and was published in JAMA last year. And it really changed the way I started to think about the pandemic. So I would highly recommend you read it if you have a few minutes. There are a bunch of different cognitive biases that have probably come into play, both at an individual level in terms of our own individual behavior. I spoke to somebody who got COVID, who thinks they got COVID yesterday, or thinks they got COVID, spoke to them yesterday, thinks they got COVID about 10 days ago, just with a single outdoor interaction. we tend to be very optimistic that these kinds of interactions we won't be the one to get COVID. And I think we've also been very optimistic with our collective decision making. I find myself succumbing to this or being tempted by optimism bias again and again and again. When we go back to spring break of last year, I never would have thought that the kids would stay out of school till June. Then if you go forward to summer, most of us would not have thought that wave 2 would have resulted in more deaths than wave 1. And here we are, either cases are going to be stable and or continue to go down, or we are going to have a third wave. And, I think some of us wonder whether we're succumbing to optimism bias again. It's pretty obvious looking around the world that if the countries that have aimed for elimination have suffered many fewer COVID-19 deaths, just to make it really stark, more people have died at Roberta Place Nursing Home in Barrie than died in Vietnam, New Zealand, and Taiwan together, 3 countries that have 100 million people. So that's pretty stark. There's been some back and forth about whether aiming for elimination might result in more deaths from suicide or other health conditions, but the data don't seem to bear that out. There are definitely lags in excess mortality data, particularly in Canada. So in Canada, this is a comparison of Canada versus New Zealand, and Canada's line stops in about October. But as far as we can tell, the countries that have aimed for elimination have not had greater all-cause mortality, and if anything, the trend seems to be that they have less all-cause deaths, fewer all-cause deaths. Similarly, some people have raised an argument that, well, aiming for elimination results in prolonged lockdowns, people can't work. If anything, the converse seems to be true. But it's probably fair to say that, if you look at this graph and see all of the countries on this, there's no clear relationship between countries with very few deaths, like Australia, New Zealand, and Korea, and change in GDP versus countries with a lot of deaths and change in GDP. So I think it's probably fair to claim that aiming for elimination certainly doesn't hurt the economy. The economy is obviously totally abstract, and individual people in an economy can be certainly hurt. And so, any sort of elimination strategy, or for that matter, any control strategy, should be coupled, in my view, with social supports for people who need help. And, pretty obvious that the countries that have aimed for elimination have been able to open up, and isolation harms are much reduced in those countries. And aiming for elimination actually works in Canada. So here is the slide showing the number of deaths in each province. Atlantic Canada and the North, those provinces and territory have pursued an elimination strategy, either explicitly or it's been implied, and their populations have suffered many fewer deaths. You take one province like New Brunswick, for example, which has a land border with Quebec, a land border with the United States. I think they've had a few more deaths than 20 now. But if you compare Ontario and New Brunswick, just a vast difference in the number of deaths. New Brunswick is obviously a smaller population, but if Ontario were the size of New Brunswick, there would have only been about 400 deaths from COVID in Ontario. Another example is Kingston, where they have essentially aimed to keep COVID out of the community. And if you look at the new cases, they've driven them down to 0, 3, 4, 5 times during the pandemic, despite being in the middle of the province in the middle of the kind of most populous part of the province between Toronto and Ottawa, and also, with a university and a prison in the town. Some debate on whether aiming for elimination is a pro-equity strategy or not. Most people here have probably seen a slide, something like this, showing that people who are brown or black are basically 4 or 5 times as likely to become infected with COVID in Toronto than people who are white. And actually, people who are brown and black have also suffered more educational harm, probably more economic harm during the pandemic. You know, whether or not an elimination strategy is pro-equity or not depends really on two things, I would argue. One is how much these things are accrued by people who are disadvantaged in one way during, you know, as a wave of COVID-19 sweeps through the province. And then secondly, by the kinds of supports that go along with an elimination strategy. And, you know, I don't know the details of what every country has done, but certainly some of the countries that have aimed for elimination have been very, you know, have provided a more robust social safety net in terms of paid time to isolate, paid time to quarantine, paid time off for getting a test than we have done so here. And you know, actually, I was struck by Kim's comment in the previous panel about how we really haven't engaged with the people who are most affected by the pandemic, and when we have made our policies. I think she said we need to be listening a lot better. I would agree with that very much. You know, I think when we, as individual clinicians, when we think about what care we are providing to our patients, we always, you know, make a decision together after looking at the benefits and the harms. But I think when it has come to making policy decisions during the pandemic, we really haven't done that as much as we ought to. I certainly haven't done that systematically, but in talking to people, you know, patients I've cared for, people in my own family, and so on, I think the general consensus among people who are most affected by the pandemic is that a more aggressive strategy coupled with social supports would have been preferred to a control strategy. And then the final thing is an elimination strategy works synergistically with the mass vaccination strategy. So, you know, I've been advocating that elimination would have been a better choice pretty much since April or May. And I've had some people say to me, you know, well, we didn't even know there would be a vaccine at that point. And, you know, it was a bit of a risky proposition then. You know, now that we have multiple vaccines that are highly effective, you know, I think it becomes even more clear that aiming for elimination is likely the optimal strategy while we proceed with mass vaccination. It doesn't mean that we need to have this elimination strategy forever. You know, it would probably be prudent to reassess in 6 to 12 months when we see how much infection is circulating through the community and decide whether we are okay with shifting to a control strategy. But I think the idea of you know, potentially experiencing a third wave or even a fourth wave before we have really vaccinated the bulk of the population. You know, when we know that every, you know, basically every death from COVID-19 at this point is preventable, just doesn't seem like quite the right strategy to be pursuing, at least to me. So some concluding thoughts from a paper arguing for an elimination approach published in the BMJ. The goal of eliminating COVID-19 is achievable and sustainable for at least some jurisdictions and will be facilitated by vaccines. These folks argue that elimination does offer equity and economic advantages. You know, I think we should be humble and have a lot of humility about what we know and what we don't know. But we also have to make a bet one way or the other. And I guess what I'm arguing is that aiming for elimination is the better bet. And these authors argue that as well. I want to end with a thought again on optimism bias. So, you know, many, one of the kind of leading cognitive psychology scientists is Daniel Kahneman, and he's advised one technique that we can use to guard against optimism bias is to conduct what's called a pre-mortem. So think about if things go really badly and you're sitting in a room with the people who made the decisions a year later, you know, if you could go back in time, what would you do differently? And I think, you know, we could actually now that we've gone through the pandemic, we can actually, or gone through part of the pandemic, we could do a post-mortem on the first and second waves. But we can also look forward to say, well, what if we go 6 or 12 months into the future and suffer through another few thousand deaths, or even a few hundred deaths, and a really severe third wave? You know, if we look back to February 2021 and say, what would we have liked to do differently? I think many of those things we know what we would do differently. Probably we wouldn't open up quite so fast. We would probably try to get even more resources to public health units and into supporting people who need time off to get tested or to isolate and quarantine, and pay even closer attention to the border, particularly the land border, but also air travel. So, you know, maybe a bit of a provocative argument. I know that not everyone who's listening will agree. Look forward to the Q&A. I did want to thank a few people who over the course of the last couple of weeks have helped refine some of the arguments. Some definitely don't agree with the arguments, so this is just shouldn't be taken as an endorsement. I just wanted to say thanks for the feedback, and thanks to everyone for listening. Thanks, Michael.
Thank you, Irfan. That was terrific. Very thought-provoking and clear. We do have some questions in the chat. I just want to start off with the first question, which is, it's not entirely clear to me what the difference is in terms of the strategies between elimination and control. And you described it as sort of, you know, getting to elimination is not the same as, or working towards elimination is not the same as actual elimination. And you sort of make it sound like maybe we just need to lock down a little bit longer or differently. So what would practically be the main differences that we would feel as citizens in Ontario if the government had pursued an elimination strategy versus control?
Great question. So I'm not totally sure, and I think every country that has aimed for elimination has done it a little bit differently. But if you go back to last summer when cases, you know, I think there were some days in Toronto where cases were in the single-digit range, and we were in sort of the low double digits, 20, 30, 40 cases a day in the province. And if the government had said, okay, we're changing course, we're going to aim to keep COVID out of Ontario, you know, and then you say, well, what would they have done differently? So I would say a few things. One, probably a lot more attention to travel and the borders right then and there, and maybe even regional travel restrictions every time there's an outbreak. So, you know, in New Zealand, for example, they had 3 cases last week and they restricted travel in and out of Auckland. So I think a lot more attention to travel. I think more investment in contact tracing, whether through paid staff or volunteers. But, you know, when you go back to August, September, of the cases that we did have in Ontario, even though there weren't very many cases, there were still sort of, I think, 30 to 40% where we didn't know the source of the case. And in a jurisdiction where you're aiming for elimination, obviously you're going to want that to be as close to 100% as possible. And I think, you know, I wasn't sort of campaigning for paid sick days in the spring, or probably not even in the summer. But I think as the workplace outbreaks as it became clear that more and more outbreaks were in the workplace, I think if we were aiming for elimination, we would have put in paid time off for people who need testing or isolation or quarantine like they've done in Australia. So I think those 3 things, travel, contact tracing, paid time off, are probably the big ones. And actually, I you know, nobody can know for sure, but I think that if we had done those 3 things in the summer, you know, we probably wouldn't have had the kind of wave we had in the fall. And so, you know, does it need a longer lockdown? You know, maybe the lockdown would have been, or maybe the restrictions would have been slightly longer in the summer. You know, we opened up indoor dining, for example, in the summer. Maybe we wouldn't have done that. But I think we would have probably escaped this second, more severe lockdown that started on Boxing Day with the, you know, the school closure and all that.
Here's a question from David Henry in Australia, our old friend who is living in a COVID-free, more or less, environment. And he asks, has politics been a barrier to elimination? In Australia, elimination has been pursued, but politicians have not been prepared to call it that, as there was pressure from the right wing to pursue control. Has that been an issue in Canada?
I don't know. I mean, I'm not obviously privy to the discussions that our elected leaders have had amongst themselves. I think there has been less debate about the strategy, than there has been in Australia. And it was in fact a report from a group of universities in Australia in the spring that convinced me that aiming for elimination would be a better strategy, even if we couldn't achieve it. I think that what's been more impactful really is what's happened in the United States, and maybe to some degree what's happened in the United Kingdom. I think if those two countries had also, like Australia and New Zealand, pursued a very aggressive approach, I think Canada would have probably fallen in line and gone that way. But that wasn't the case.
So, as you mentioned, this is a controversial approach, even among public health people and health system folks. And here's a question, wondering about what the best approaches are for communicating and getting buy-in for elimination strategy from the general public.
Yeah, so, I think the polls that have been done have again and again shown that the public supports restrictions. And I think that, I'm not sure that we have taken the time to get really, detailed feedback from the public about things like how much they want to invest in contact tracing and so on. But, the economists who've looked at this say that the return on investment in contact tracing is very high. On the order of 10 to 1 or 20 to 1, which makes intuitive sense. I mean, contact tracing is not a particularly expensive intervention. Does require, a little bit of a management infrastructure and so on, of course, but it's not an especially expensive infrastructure. So I think that, I don't know this for sure. And I think, of course, it would depend on how it is presented to the public. But I think if you took sort of a citizens council type of approach, and if you gathered citizens who are the folks who are, randomly selected, people who will be affected by the pandemic in kind of the same way as society would, I think that there would be support, is my gut feeling.
Okay. We have about 3 minutes left, Irfan, so I'll just give you the countdown. You pointed to examples within Canada, the Atlantic provinces, as well as even Kingston here in Ontario, where they seem to have, whether they call it elimination strategy or not, have done a better job. And yet, those jurisdictions or sub-jurisdictions are really subject to much the same lockdown constraints as Ontario is. To what extent are there other factors that go beyond just how well you contact trace and how well people are abiding by physical social distancing and so on? To what extent does it go back? Does the outcome depend on the makeup of the communities, the types of workforces and workplaces that you have, and as well as potentially some random factors that you might never really be able to put your finger on?
Yeah, it's a great question, and I don't know. I think we should be very, humble. There's still a lot we don't know about this virus, and I don't think we know what our situation will be like a year from now. And I think people will argue that Peel is very different than Kingston, and of course it is. I've been to both places. They are very different. But I guess the question I would ask is not whether we can achieve in Peel what was achieved in Kingston, but if we had aimed for elimination, would we have better outcomes in Peel than we do right now?
Okay. Maybe the last question I'll ask is this. Is it ever too late to start to aim for elimination? Is the pandemic ever too prevalent, cases too widespread to sort of say that we can do this? Or would your argument be that at any point it is the right strategy to target?
you know, I don't think there's, like, from a technical perspective, I don't think it's ever too late. I mean, Melbourne had a big wave in the summer. Actually, Newfoundland very recently has had a very large wave relative to the size of its population. And, you know, I don't think they have explicitly used the word elimination, but if you look at what they're doing, they're trying to drive cases back down to zero. So I think they're basically pursuing an elimination strategy. So technically, I don't think it's hard. I think where it gets hard is sort of politically and psychologically, because you know, at this point in the pandemic, for us to switch in Ontario or in Quebec or any of the other provinces that have been very hard hit, we would have to acknowledge essentially that we didn't take the right approach, at least for wave 2.
Irfan, thank you so much.
Sorry to leave you on that downer note. But I think the pandemic, I mean, it's very clear the pandemic will end. You know, how it ends, you know, I don't think anybody really knows. But hopefully the next forum next year we'll all be back in person and shaking hands. Absolutely.
I agree with that sentiment entirely. Irfan, thank you so much for a terrific presentation. Again, a virtual round of applause for your presentation, which is a real tour de force. So for everyone, all the conference attendees out there, we're going to take a brief break. We'll be back at 2:30 p.m. sharp for the last segment of the event, which is a terrific panel presentation discussion. So please come back at 2:30 sharp. Thanks very much.